Hello, everyone. Thank you for joining us today for another Teaching Essentials, all about question writing for assessments, something we can use a lot of information about. Sometimes that's a difficult part of teaching is that assessment piece. So we're excited to hear today from Dr. Karli Wittorf, Dr. Jim Smith, and Dr. Cassie Eno from the School of Medicine and department, more specifically the Department of Medical Education, but all professors and teach with our learners, and they are no stranger to question writing. So we're excited to have them here. If you have questions, please put it in the chat, or you are free to unmute yourself and ask a question along the way. Or at the end. And you can get CE credit for this session. We do ask that you fill out a very short survey in order to get that CE hour. And I'll let you know more about that towards the end of the session. All right, Dr. Eno, if you'll go ahead and get started.
All right, well, welcome. So this is, as Jessica said, the fourth in a four-part series on teaching essentials. And so we're going to spend a little bit of time talking a little bit about the philosophy of assessment and how to write questions. But we've chosen to spend most of this time actually going through some question examples with you all and doing some kind of live question editing. So we appreciate your participation and questions. We'll try to get through our more didactic portion quickly so that we can get to the questions. So Karli, the next slide. Yeah, we've already kind of went over this, so we'll go to the next slide. So when we think about assessment from kind of the 30,000 foot view level, the thing that we need to remember as healthcare practitioners and educators and folks in this space is that we have a social contract with folks and with the profession of self-monitoring. So part of the responsibility of physicians and other healthcare providers is to ensure that we are appropriately monitoring physicians or other physicians and others within our practice to make sure that patients are not harmed. So we have a responsibility to do things like board exams and participate in board exam writing to ensure that we are helping to self-monitor the profession, because of course the alternative to self-monitoring is external monitoring. So when we think about that, there's different ways that this is kind of implemented along the educational continuum and spectrum, more so towards the residency side of the spectrum and the graduate medical education side. Folks are starting to talk about entrustment decisions, entrustable professional activities. So this idea that rather than just giving students an assessment of how they're doing on a scale of 1 to 5 or on a some undetermined Likert scale, we talk about and think about this in terms of how far we trust our learners or at what level we trust our learners to carry out some sort of care activity. So do they need to be directly supervised? Can they practice independently? And then at some stage of the game, can they teach others to engage in that type of activity? So when we move this construct from more of a knowledge to more of an entrustment decision, it kind of gives this sense that there's a judgment call that's kind of being made there as well. So we can kind of, it helps to shift that framework from, you know, a simple test of what folks are learning to a test of, or a judgment call on, do we think that this person should be out among the profession and should be seeing patients, and that we can estimate that there's a relatively low risk that harm would be done to patients by this person practicing. So next slide, Karli. So when we think about this in the framework of assessment, we think about actual learner competence or actual levels of entrustment. So is this someone that we want out practicing with patients? That's really the decision that we're trying to make. Are they competent or entrustable, or are they not competent and not entrustable? And we have assessments and evaluations and tools and different things that help us to get information relative to that entrustment. So when those things align, the actual learner competence and the assessment or evaluation, we really don't have an issue or a problem, right? So the tool is telling us the learners are competent, and they go off and practice. It's great. The tools tell us the learner is not competent. They actually aren't. They leave the profession or leave the educational system. No harm is done. So if we think though about when these two constructs don't line up, so if we think about a competent learner that is found to be not competent based on our assessment tools, in that case, we have a mismatch, and that is at the detriment of the learner, right? So in that case, we probably are still concerned because we want to put learners into practice. We don't want to be telling them that they're not competent when in fact they are, but the harm there is to the learner. What I would say is the more concerned case, if we have a not competent learner, but we're saying that they're a competent learner, we're actually then putting someone who's not ready out into practice, out into the profession. And this is where we risk the possibility of harm, or what we consider in this little 2x2 design, a false positive. That's really where there's possibility that we're doing harm to patients and a harm to arguably society and the profession. So we really want to think about this from a standpoint of how are our tools, or are our tools giving us accurate information about the competence of a learner? So when we think about that, Karli, you can go to the next slide, about kind of all of the things that we're trying to assess in our learners. We think about our kind of core medical education competencies, and this, these are specific to medical education, but similar competencies across all of the health professions. When we think about all of these things, we're also trying to assess a lot of different things. So Karli, if you'll click button, you can click through those. We're trying to assess knowledge, skills, behaviors, professional attributes. We're trying to develop these habits in a learner. So we really need not just one tool, but we need kind of a toolkit that allows us to assess students. So we're going to talk primarily today about multiple choice questions, but we wanted to frame this a little bit with the idea that assessment isn't purely multiple choice questions. It's one of the tools in our toolbox. So we're going to start talking a little bit about competency-based medical education, just to frame kind of where multiple choice questions fit within that continuum. But I'll turn it over to Jim for that. Thank you.
Yeah, thanks, Cassie. And Karli, I'll just hold up my finger and that will indicate the next slide. So as Cassie introduced, we have moved through several hundred years of medical education. I apologize to the non-physicians in the group, and I don't mean to be exclusive of other healthcare providers or actually any other profession. But the three presenters today are from the School of Medicine. So I'll talk about medical education, and some historic context is worthwhile in this, and learning about how we do evaluation in the formation of physicians. So historically, in the United States, we had this nascent set of colonies that turned into a country, and we didn't really have those historic educational systems that Europe did, in the 17th and 16th and 15th centuries, and going back in time. So we really had to kind of fend for ourselves. And initially, healthcare was delivered by independent practitioners, not just in cities as they developed, but out in the country. And the type of education would be most appropriately explained as an apprenticeship, where a practicing physician would take on a learner, and the learner would be with that physician for some 3 to 6 years, being at the bedside, doing pharmacy work, compounding, and so forth, and learning about the practice of medicine, and being evaluated by one-on-one observation, with the ultimate competency being the independent practice that would be allowed by the supervising physician or the mentor at the time. The rise of classroom education came about in the late 18th and early 19th centuries, when it became apparent that rather than having a one-on-one relationship that was rather inefficient, physicians could actually get several students and put them in a classroom and talk to them, basically give lectures and have them read, not just as a form of being more efficient in medical education, but also for proprietary reasons, getting money, getting tuition, and then endowing upon themselves a title of professor for professional advancement and social stature. So this is pretty well known to medical historians that the U.S. was a little bit shameful, but all of a sudden these proprietary for-profit medical enterprises developed in cities and in the hinterlands, smaller townships and so forth. Of course, the product of this type of education was suboptimal, and there was a huge public backlash to the ineffectiveness of the physicians at the time. Of course, this was before we had antibiotics or an understanding of even the internal organs of the body, but that did push sectarian medical education to develop. So not just the regular physicians and the allopathic medical education processes, but also other medical sects. So homeopathy, eclectic medicine, osteopathy actually came out of this milieu of disenchantment with the practitioners of the time. It also led, by the way, to state licensing boards, because the citizens through legislature were fed up with the type of practitioner that was being pushed upon the communities. And one of the important transitions became the move of these, or the eradication of these proprietary medical schools in favor of medical education that became university based. Karli, next slide. Yeah, and people will be familiar with the Flexner Report of 1910, which really was considered the inflection point, but the move towards university-based medical education was already occurring in the late 19th century. And with this, medical schools were assimilated into the university environment. So medical education was delivered in medical departments of a university. And thus, medical education and the educators acquired the administrative and financial and pedagogical characteristics of university. So moving from the apprenticeship with one-on-one assessments into universities, where obviously there is testing. Next slide, Karli. Now, the testing in universities would be competencies or assessments chosen by the faculty, where competency was defined by grading of students. In other words, ranking or rating or sorting students based on results of some form of testing. Initially, the testing was verbal, so dialogue between professors or board members or presidents of universities with the actual potential graduates. And then with just simple changes, the advent of a pencil and paper, all of a sudden writing assessments came about. And these form of assessments tended to drive performance on exams rather than mastery learning. And for us in healthcare, the application to patient care. Next slide. And so we're sort of stuck in this position of having to have efficient and expedient methods of assessing our health workforce as it develops. But perhaps, and many of us in healthcare can recognize this, perhaps the best assessment that would be most appropriate to the patients and the populations from which they come would be workplace based evaluation rather than multiple choice questions and so forth. So workplace-based evaluation, WBE, you'll see in some of the medical education literature, really is at the heart and soul of what we're trying to get. In other words, we want our providers not to just know things and not to just be able to do things, but to apply those in the complexity of the healthcare environments that we find ourselves in. Rural clinics versus quaternary care centers, ambulatory centers and clinics versus long-term health care facilities and so forth. And all of us that have, been in hospital systems know that, it's one thing to know how to put in an order for certain medications. It's quite another when, say, Epic is not working, or when we want to get a blood count and the CBC machine is not working, or the blood pressure cuffs we can't find. So, the contingencies and vicissitudes of all of the things that can happen in a workplace seems to be where we need to really focus our assessments. So, Karli, next slide. Here's Miller's pyramid, just so that we can kind of begin to focus on what we want to accomplish today. So at the base of the pyramid, our learners need to know a certain amount of things. Sometimes it's very small, sometimes it's a huge set of factual knowledge that they have to assimilate. And then as you work up the pyramid, it's somewhat self-evident there. So knows, and then knows how, shows how, and actually does. So a good analogy would be us attaining the ability to drive on the streets. So initially, we have to learn the basic stuff that we get from those little books when we're teenagers, and have to know what a stop sign means, and do you have to slow down 300 feet in front of the car in front of you, and so forth. And then as we learn that and pass the written test, we have to show that we can step on the brakes and steer. And then finally, we have a driver's test, typically with somebody that's credentialed to sit with us, and we have to drive on the road and not hurt people and not drive on the sidewalk. We have to actually be competent. And then there's another step, which is to recognize our role in society, which is to get a license and have a license, and then have ongoing assessments like don't get arrested, don't speed, and so forth. So, Karli, next slide. So, getting, education and driving is similar to what we're talking about here, workplace evaluation. Can our healthcare learners do things in a clinical environment? And again, going back to the university-based environment that we've been in for 150 years or so, this is where we need to be going. Next slide, Karli. But we have to start somewhere, and we have to start with our learners at a basic in a basic spot. So that's where multiple choice questions become very important, because although we are looking at workplace based evaluation and observation, we got to start in some place where we can test competencies in an efficient and meaningful way. Next slide, Karli. Now, I'm going to turn this over to Karli, but what I want for the audience in the next 5 or 10 minutes or so, as Karli is talking, is to, in the chat, put a specific topic, maybe with learners that you have, or something that you've wondered about, just a basic topic, like, let's say, blood pressure, and then the intended learner that would be assessed in whatever educational environment you're in. So maybe blood pressure and nursing, or ethics and physical therapists, or something like that. And then as Karli talks about how to structure a multiple choice question, we'll actually practice this in a few minutes. So Karli, you're up.
Yep. Say thanks, Jim. So hi, I'm Karli Wittorf, and I'm going to be talking about kind of just the anatomy. I'm an anatomist, so kind of pun on words, of a multiple choice question. And sorry for my voice today. I'm still getting over a cold, so still pretty stuffy. So kind of the layout, how I'm going to go through for multiple choice questions is we're going to start with the two main categories, two main types of questions that you see when writing multiple choice questions, as well as in the main components of a multiple choice question, some general rules to follow when writing them, as well as some common mistakes you've seen. And again, we're part of the Department of Medical Education, primarily work with medical students. And so for the basis of my presentation, I followed the National Board of Medical Examiners. They have a constructing questions, written test questions for basic and clinical scientists, their most updated edition. But a lot of different, and I have a few references at the end that kind of follow similar rules for writing these questions. So moving into first, the two kind of types of exam multiple choice questions, you can see the first one is called true false family. And so this just requires test takers to select all possible responses that are true, that follow true to the statement or the question that you're asking. And the second type is a one best answer family. So in this, different from a true false, is this requires the test takers to select one single most accurate answer. And so actually, this type, the one best answer family, is the most widely used multiple choice question format, as well as then actually the NBME, so the National Board of Medical Examiners, actually suggests not using true or false questions when possible in writing with them. And also for their board exams, they've done away with using true false family questions. So what is the main kind of components of a multiple choice question? You first, of course, have the question stem, which usually in part of the question stem is you have a lead-in question. So whether or not, in this case, it has a nice long clinical vignette or kind of relevant background history you can have in the question stem. Some cases you might just have the lead-in question by itself. You don't always necessarily need the background information, as well as then the second part is, of course, your answer options, where you, of course, have one correct answer followed with anywhere to 3 to 5 distractors. So questions that are not the best answer. So kind of some rules for writing one best answer questions. The first one, of course, is you need the question stem and the answer options. They must be clear and straightforward. So again, that's where you go whether or not you need that relevant background information or clinical vignette, or you just need the lead-in question. You very much need it focused and clear for the students. Again, the lead-in question should be focused, clear, and ideally complete. The best case scenario is actually for the students to be able to just read the question themselves and answer it without even looking at the multiple choice question. So this is very much the cover up and see kind of approach, is how ideally it should be when writing questions for students. The third rule is that all answer options should follow consistent structure and be plausible. And then the last one is that distractor answer options can be partially or wholly incorrect. So very much under this one best answer question, there's only one option that is the best answer. So therefore, the rest of the options don't have to be completely incorrect. And again, these rules for writing one best answer questions are very similar to writing for true or false questions as well. So when moving through and writing through questions, even though those are kind of the 4 main rules when writing them, there's still some common mistakes made. So very much so, one common mistake you might see is that the question stem or the answer options are overly long, unnecessarily complicated, or contain very vague terms. So again, just making sure it's concise. You have kind of one concept in mind when writing these questions and wanting your students to answer them. So very much keeping it kind of just the necessary information that's needed for the question. NBME actually suggests question stems to not contain negative phrasing. So very much like which of the following is not, or all of the following except should be excluded. Very much you want it to keep the students focused on what is the best answer and not switching to that mindset of, well, which one is not the best answer. For another common mistake seen, question stems contain grammatical cues, which make it easier to eliminate distractor answer options. So very much you have the correct answer option that matches the grammatical cue within the leading in question in the stem, but then your distractors don't match that. So that makes it very easy for students then to be like, oh, well, this one, when I read it out loud to myself, it doesn't match what the question is asking. So therefore I can eliminate that one much easier. A few other common mistakes seen is very much the language or structure of the options is not consistent between the two. You very want them to be very similar, because this can lead to very much if you're focusing on writing that perfect one best answer option, what tends to happen is that correct answer is a lot longer, very more specific or more complete, or a lot more complex than all of the distractors that you've added in to just kind of add as fillers. So you very much want them to be consistent so that honestly, just looking at the answer options, the student can't just pick out which one they think is right because it's the longest one. You can also run into, when trying though, to add in and make it more consistent or longer or more specific, is you can add in what's called convergence to the answer options. So this just means that the correct answer happens to have the most in common with all of your other distractors. So very much add in an example from the NBME book for this. And so for this question, going through kind of for looking at local anesthetics, and even if you don't know about local anesthetics, how a student might work through this question is very much you can see there's two answer options that have cationic form and 2 that have uncharged form, whereas there's only 1 with the anionic form. So very much so a student could automatically just cross out the anionic form because it doesn't have kind of a matching partner with itself, whereas the other two does. And then going to the second part of the question, very much comparing how many of there are for inside of the nerve membrane versus outside. You can see that there's 3 inside versus 2 outside. So very much that the student, without even knowing the content itself, could get eliminate down to B and D for their answer options for what they think is the best answer for the question. And then for kind of some phrases that should be avoided when writing these, very much NBME suggests not using all of the above or none of the above, because very much this switches from a 1 best answer option to a true or false question option. So very much changes the type of question that you're asking. Also avoid using absolute terms such as always or never, because it's very rarely that something will happen always all the time. So very much the student will kind of lean away from absolute terms because of that little gray area for certain questions or certain phenomenons, as well as then avoid using the same word or phrase in the stem as well as the answer option, because very much too, it can cue up the student for, oh, if it's very similar wording or similar phrasing in the question, but one of those answers has the similar phrase, it's easy to pick that out without actually even knowing the content. And so we'll move into working on some examples, and I'll actually stop sharing my screen. Because I think, Jim, you have this set up for the chat GTP, right?
Yes, I do.
Okay.
Okay. So thanks to Marilee. Marilee asked about creating a question related to end-of-life care for nurses. So let's see if this so-called artificial intelligence can help us out here. Let's see, what would be a good question? Let's say test question for nurses related to end-of-life care. Okay, is that fair? Everybody okay with that? A good test question. So describe the principles of palliative care and how they apply to end-of-life patients. Okay, that's not multiple choice though. How about a multiple choice question? Let's try that. Okay. Which of the following interventions best reflects the principles of palliative care for a patient nearing the end of life? Marilee, is that close? You can unmute or you can just put something in the chat.
Oh, I think that's good.
Yeah, okay. Karli, help us out here. What is this a good question or is this not a good question?
I would say as you initially look at it, it on the surface kind of looks like a good question. I would say they do very good of, I'd say, keeping kind of the grammar similar, which is very much what you want to look out for, like administering, encouraging, withholding, recommending. They stay in that good format. For these, though, looking more at it, I'd say you do see that B tends to be a little bit longer than the rest of them. So trying to keep them at a little bit similar length is a little bit more recommended.
Yeah. Yeah, any other comments? In my question writing, I tend to look at the stem. And in this case, you know, there's a single question there, but I always wonder if it might be better to create a vignette of an actual patient scenario. And then, so for instance, the Chat GPT gives us that a patient is nearing the end of life. And I wonder if we could create a narrative for which it is obvious the patient is nearing the end of life, for which the learner would have to recognize that and then pick an answer that best reflects the principles of palliative care.
So along with that as well, having a vignette, somebody's asking a follow-up question. Is it possible to have a higher level of difficulty with ChatGPT after you already have this answer from them? Because I even I think people that haven't even maybe studied palliative care could probably get to the right answer pretty easily. Is there something you can go beyond this, or say maybe add a vignette?
Let's try it. What would be a more
You,
difficult?
you can create a vignette. So in the prompts that you are going to write, you can put is the gender, the age, the problem that the patient have, and then you can build the vignette. You give the characteristics of the vignette and then the question, and then they are going to prepare for you. You can go
Thanks,
deeper.
Manny. Let's keep talking. Let's see what we get here. So Manny, yeah, look at this. Actually, ChatGPT has helped us a little bit by creating a Mrs. Johnson. They seem to be conflicting about letting her go peacefully. So this sounds very, very much like what we talk about in our ethics and humanities series for the medical students. Karli, what are your thoughts on this?
Okay, I'm just finishing reading through the answer options.
Yeah.
So one suggestion that can sometimes be helpful is to also take kind of similar to what Karli was talking about earlier, but different, is to take away the vignette and see if it still requires, if students can then answer the question without the vignette.
That's what I was thinking about too, Cassie, because I actually read the answers first, just knowing the little bit that I know about palliative care. I read the answers first, and then I thought maybe I don't need to go to the vignette, because there might be a couple good answers in there.
Mary has noticed distractor C is an unreasonable option. And Mary, why would you say that?
I think that was on the last question.
That was in the last.
Oh, I'm sorry.
question.
I'm sorry.
Yeah.
I'm
The
just
last
paying
question
attention.
would have been overly simple,
Yes.
I think.
Mm.
I mean, I could have answered it probably.
I think this one is really easy to answer too, even if you don't have much background.
Yeah.
So let's think about how we can make it more complex. What do we have some suggestions from our participants here that would help us to make this more complex?
Somebody put in the chat to add legal considerations.
Yeah, very, very good. That would certainly add a layer of complexity. In fact, thank you, Robert. Let's see. And you, whoops. Add legal complexities to this question. So ChatGPT has put an advanced directive narrative in here.
I'd say as we're moving into adding more to it, as you can see, because like it still keeps B as the best answer, you can see how it more often adds on to B a lot more. So it's very much now too looking like B is now 3 lines versus the rest of them of just looking at kind of structure wise. Of very much, you can see ChatGPT is very much focusing on the best right answer and not as much on the distractors as it's formulating the questions.
And if I may, that second sentence in distractor B could in fact be a 5th distractor by itself. Ensure compliance as a E option.
Oh, yes. In fact, that's like another sentence,
Mm-hmm.
that
Mhm.
one answer, which I've always tried to avoid. If not, we should absolutely avoid that.
Mhm.
Yeah.
One of the
Good.
things we do in nursing too, and I don't know if it takes away from the making the longer answers the most obvious, but we always, or we intend to stack our questions so that the shortest answer is on top and they get progressively longer toward the end.
And do you notice the students erroneously going for the longest answer or the shortest answer?
Can't say that I know the answer to that.
Yeah. Melanie suggested ethics for pharmacists. So let's see, can you create a multiple choice question for pharmacy students? Let's pick the use of placebos because pharmacists are engaged in those discussions commonly, even outside of research protocols. Let's see. For pharmacy students related to the use of placebos. So typically, it seems like ChatGPT will give us just like a 1 question test item with 4 answers. Let's see if we can predict that. We can sort of predict that.
Yeah, and Evis, thanks for the comments about ChatGPT. We're really using this just as a demonstration, not necessarily as a advocation to use ChatGPT for questions, but we thought it was better than selecting potential questions that individual faculty had written and making adjustments to them.
How
Yes.
about if you have these 4 options, correct, and one of them is correct, and you say that ChatGPT from the correct answer modify and produce the other options. So they are going to play with 1 question only, 1 answer only.
And I think so when and my concern is with a single question without a vignette, there's almost a tendency to look for a memorized answer. So in this one, which of the following statements best describes the ethical considerations surrounding the use of placebos in clinical practice? So very generic. So there's no vignette. It's just like in general. So the learner may look for word associations with placebo. Placebo discouraged. Placebos treatment failures. Lack of pharmacologic effect. So there may be not, learners may be just looking to word associations rather than any synthesis of what this information may mean. So let's see, let's try this. Whoops. Can you add a vignette to this question? And let's see, are those the same? Yeah, so it looks like it looks like there's a vignette that's been added, but the same question, excuse me, the same answers are present. And it looks like here's the, as a pharmacist, what is the most appropriate action to take in this situation? Well, let's see. That doesn't make any sense. So it looks like the vignette is up here, but the answers don't follow. There's no answer for this. What is the most appropriate action to take in this situation? I personally like that format, like the learner then needs to answer correctly or pick the best answer in what are you going to do about this clinical situation. So they have to know the basic knowledge, but then they have to take that, assimilate it, and do something appropriate.
And I'd say that helps too in this scenario, because the initial question that it wrote, it doesn't kind of follow that ideal of like, you could cover up the answer options and answer the question. Like you have to read the question options to answer it. Whereas like a vignette, if you add the background kind of information, it sets up the story a little bit to then have the little bit more vague kind of lead-in question.
Yeah, other comments. Keith, does your exam construct resource comment about using of the following in the stem of the question? Karli, do you recall anything from the USMLE about so USMLE for people in the audience, that's our that's the National Board of Medical Educators, NBME, and they come up with test items, and they have a book on how to write them. And so, Karli, any thoughts on that?
I'd say they suggest not, like they suggest having it more complete, but I would say they're fine because they do also give examples of when it kind of just says of the following and then answer, or like the example I gave in there when it was kind of going through the convergence, like that wasn't kind of a complete idea or a complete question. So they suggest not, but they're also not like it's not a hard no.
Yeah.
As another helpful resource, the NBME format has just also a list of lead-in questions suggested so that you can kind of borrow from there as well. Robert, to your answer, no, or to your question, no, the NBME no longer uses the A and B, A not B type of formatting.
Yeah, they did it away kind of the same with of none of the above or all the above. Then they say it goes more kind of into that true false kind of category, and very much of like it's better for like a one kind of best answer format.
Somebody else asked in the chat, do you three start with Chat GPT and then make adjustments for your assessments? Even with the incorrect information or incorrect answers, do you feel like it's a good starting point?
I do not personally. We thought, again, it would be a good starting point for today so that we didn't have to select individual faculty questions. And we thought we could also use kind of the audience crowdsource of what would be interesting questions to talk about as well.
I'd say I'm the same. I have not. I've heard other people use it to kind of just like more helping, I feel like, with the distractors a little bit of a base, more of like they know what they want to write, they know what they want their answer to be, but kind of just trying to come up with kind of the filler kind of distractors and then modifying from there.
Yeah, I think Chat GPT has been around for what, 18 months or so, and as pointed out, there are you know, what do they call them, hallucinations, or you know, in these artificial intelligent software programs. So we certainly would have to be careful. I view Chat GPT as sort of a thought-provoking resource to go to come up with ideas. You could put, so for instance, when I construct vignettes for test items, sometimes you know, if it's late at night, I'm just tired and I can't think of a clinical scenario. So I might put in what is a clinical vignette related to the neuro ICU in a patient that has a stroke or something like that. And, some ideas pop up for which I can then take and, construct some question around the thought there. I've never copied and pasted any of the questions. And I probably wouldn't, no matter what.
We do have another question that came to me in the chat that takes us back a little bit to the CBME, Jim. I don't know if you want to start taking open questions or if you would like to stay on reconstructing these.
Not at all. Well, I think we can
Okay.
take open questions or dialogue.
Let me go ahead and start with this one. I think this would be for you, Jim, as you were talking about CBME. They said, how would this affect, so they're talking about CBME, your section, how would it affect the length and subsequently the cost of education for health sciences learners?
Or
For requiring competency-based education in any of these fields for Creighton specifically.
well, I think so when you look at specifically medical education, we ultimately get to competency-based assessments by the time we get to both board certification and maybe not licensure, but moving through our current system of education, competencies have to be determined. And I think the shifts that we may see, or what I hope that we see, is that when you think about competency, it's categorical. We can be competent or not yet competent. And I hate to use incompetent because we make a commitment to our learners to say we're going to do everything that we can, and we are optimistic you're going to gain competency, but you may be at stages of education where you're not yet competent. But we get to that point where somebody is competent, say I like with our medical students, walking in a room and introducing yourself and taking a blood pressure. Okay, there's a competency to that. They have to be comfortable. They have to place the patient at ease. They have to feel competent and confident that they can take an accurate blood pressure assessment. And so the issue is, once they do that, there is not just no further advantage to saying who can do that better, like who gets an A or honors and who gets a competent, who just gets a pass. What that does is there's many different negative effects of that type of stratification further past competency. And so as we move, I don't see this competency-based evaluation as being more onerous or more expensive or more time-consuming. It's the way we interpret that which is already functioning. And it would, sort of relieve some of the pressure of us having to figure out who is more polite with patients, who gets an honors for being more polite than somebody else who's polite or with professional behaviors. Because again, you take a driver's license test, you don't get an A for driving or a B or a C or a D minus. It's all you pass and you get a driver's license and you can go out and drive around on the road. And I see the momentum building towards, in healthcare, something as important to all of us as healthcare, and specifically in medical education, that we want to get there, because that allows us, that sort of unleashes innovation and letting the learners perhaps not be in lockstep, of a 4-year medical education. We may have some people that are competent right away in something, and we shouldn't make them have to, sit around for 4 weeks waiting for everybody else to catch up. We should be able to come up with individualized, programs of education. And it's the right thing for the patients that they're going to be taken care of, and the ones we're taking care of now. So some of that's philosophic, but that's how I see it.
Looking at the other side, just a follow up to that, Jim, looking at the other side of that, if a learner is not competent yet, does that extend their education as far as time and as far as money? Or do you see that going back to the university to be able to cover the extra cost of time?
Yeah, so Jessica, who's this person asking these questions? Somebody's very perceptive. And somehow I'm not seeing that in the chat because I
There,
want to.
the follow-up was me.
Okay.
Yeah.
Oh, okay. All
The
right.
follow-up was just me to
Okay, all right.
your answer.
Yeah.
But then somebody had directly asked me.
Yeah.
If I can jump in, so where I've seen the deceleration, which I think is one of the terms for that, more than an undergraduate medical education is in the residency space. Because once you complete residency, you should be able to be entrustable to both practice independently and eventually teach if that's your path. So those decelerations don't necessarily come with a detriment to the student cost because they're, an employee at that point. There's some implications for the program in terms of the complement of students that they're able to bring in based on numbers. But that's where I've seen more of the deceleration happening than in undergraduate medical education.
Yeah, thanks, Cassie. And Jessica, so the paradigm, so here's where some innovation in education might take place. The paradigm we've had is students are enrolled in a medical school and pay a standard tuition for each of 4 years in the average med school in the US. And the tuition is independent of credits. And one way to modify that, which I think we should explore, would be rather than pay per year, you would pay per credit, like many of our grad students do. So in other words, you have to assimilate so many credits to get the medical degree, but we give the student 3 to 6 years to do that, and they pay as they go. For the student that says, I feel like I want to take a year off for having a child, having a family, or the student that says, man, I love working with Karli. I want to delve into anatomy sort of off, I want to get off the highway here for a little bit for a year, maybe earn a master's, and I'll, pay for the credits. But if we allow them to pay per credit, then that offers a much more individualized and personal approach to medical education, rather than, again, the lockstep. First year you have to do this, second year with almost no variation. Somebody could come in with a PhD in biomedical sciences, and yet we make them take the first year and pay the first year's tuition of something that they may be teaching in other circumstances. And that doesn't quite make sense to me, but and it didn't make sense, by the way, to Flexner in 1910, and so we're still, again, we've assimilated and taken on the university atmosphere of to some extent of, you pay tuition for a whole year. So.
Thank you for that.
Yeah.
Any other questions? You can unmute yourself. You can add things in the chat. We really appreciate your time, Karli and Jim and Cassie. Important essentials for assessment.